The cranial cruciate ligament is a primary stabilizer of the stifle joint, which is essentially the dog's knee. It prevents the tibia, the shin bone, from shifting forward excessively relative to the femur, or thigh bone, and also helps limit internal rotation and hyperextension. When this ligament ruptures, it's one of the most frequent orthopedic problems dogs face.
And this rupture leads to instability in the stifle joint. This instability is a significant factor in the progression of osteoarthritis, a degenerative joint disease, and can also lead to injuries of the menisci, which are shock absorbers within the joint. A core part of this instability is what's called cranial tibial thrust. This is the forward force on the tibia that happens when the dog is bearing weight, due to compressive and muscular forces acting on a backward sloping surface on the top of the tibia, known as the tibial plateau. This forward force was the basis for developing procedures that change the angle of the tibial plateau.
One such procedure is the cranial closing wedge ostectomy, first described back in 1984. The idea is to surgically remove a wedge of bone from the tibia and then close the gap. By reducing the angle of the tibial plateau, this procedure reduces or even eliminates that cranial tibial thrust, providing dynamic stability to the joint during the weight-bearing phase of gait.
However, the traditional cranial closing wedge ostectomy technique has some recognized drawbacks. These include its inherent geometric imprecision and the effect of shortening the tibia, which can potentially lead to the stifle joint straightening too much. Researchers have also found that in this procedure, because the bone cut is performed away from the joint center, the upper part of the tibia pivots cranially, displacing the intercondylar eminence and causing a shift in the alignment of the long axis of the tibia. This tibial long axis shift affects the angle of the tibial plateau after surgery.
Residual instability in the joint from inaccurate correction is a disadvantage of cranial closing wedge ostectomy. This has led to the development of several alterations to the original technique. Modified cranial closing wedge ostectomy techniques were more recently described adaptations that included surgical plans designed to more accurately and repeatedly level the tibial plateau to the desired 4 to 6 degree interval, while minimizing tibial long axis shift and its impact on tibial length.
Instead of the traditional right-angle wedge bone cut, perpendicular to the tibial long axis, as designed by Slocum and Devine, one modified technique described in 2013 used a juxtaarticular isosceles wedge bone cut, 5 to 10 millimeters distal to the tibial tuberosity, leaving an intact small caudomedial cortex or hinge. Another alternative proposed in 2017 was also based on a juxtaarticular right-angle wedge cut, 3 millimeters distal to the tibial tuberosity, with the distal bone cut intersecting the proximal bone cut at approximately 66% of the distal bone cut's cranial caudal length. Lastly, a technique described in 2018 also used a juxtaarticular right-angle wedge cut, 2 to 3 millimeters distal to the tibial tuberosity, but altered the location of the wedge's apex, or point.